Hello and welcome. I'm Dr. Ramza Diamanti.
And I'm Dr. Nikreus.
In this episode of ESCRS Refractive IOL video interviews, we'll share our insights and experiences with EDF lenses, along with practical tips and tricks. We'll focus on strategies for educating and counseling patients about presbyopia correction, addressing their concerns and setting realistic expectations. The 2024 ESCRS Clinical Trends Survey revealed that 39% of respondents proactively discuss presbyopia-correcting IOLs with all qualified patients, while 36% do so only with some qualified patients. How did you educate cataract patients about presbyopia correction? And when does the patient education process begin in your practice, Nick?
Well, in the Netherlands, we are obligated to inform patients about all possible solutions. So we have to educate or inform all patients about all the various options. So we have to discuss trifocals, EDF lenses, and so on. But only, of course, if they're eligible, then we say it's an option for you. If they're not eligible because of comorbidity, then we say these lenses are available, but they're not suited for your eyes, and for the best vision in your eyes, you need to have a monofocal lens. Preferably, of course, the information starts when they get an appointment for at the clinic. But in practice, I have to say, we often only start giving information when we diagnose them with cataracts, and we inform them that a surgery is necessary, and they confirm that they would like to have surgery, and then we inform them about these various types of lenses.
And what key talking points do you cover when discussing available lens options with patients interested in presbyopia correction?
Well, generally, I discuss that we have several options to become less spectacle dependent. So that we have either put in a monofocal that they see well at far, but for intermediate and near, they need spectacles, or like an EDF lens that they see well at far and intermediate, but within 50 centimeters, they need reading spectacles. And then you have the trifocal lenses for far, intermediate, and for reading. And I always say I try to say not for near, because many people also think that they can put a splinter out of their finger with a trifocal, and that's too small. Yeah, so I try to say for reading.
Perfect. And aside from the patient-doctor conversation, are there other effective ways to educate patients? For example, staff technicians, brochures, websites, video materials, and newsletters?
Yes, we all give a flyer to the patients about the various lens options that are available. So we provide verbal information in the outpatient department at the visit, but then we give them a flyer with them, and they can read that in their own time, discuss it with their family, friends, and then we'll get back to them at a later point if they would like what kind of lens they would like to be implanted.
I don't know how Dutch people are, but Greek people, they need some time to digest the information before they decide what to do. So they need their own time with the information you've given.
It's the same in the Netherlands, and I heard the other day, the thing that I mean, in the Netherlands, the houses are very difficult to buy, and there's less time to think about buying a house than to think about which lens option you're going to choose.
That's interesting. What's your approach to lens selection? Do you make a recommendation to the patient, or do you offer multiple options? Is the final decision yours, the patient's?
It's a combined approach. So I do give all the options, and I try to express what the pros and cons are of each option. But in the end, it's what would be possible for the patient. So looking at the eye, but also looking at the personality. I do give either an option, for example, that if you have a very irregular cornea, I say, okay, a trifocal is not for you. For sure. So they can choose the other lenses. But if any lens can be implanted and they will have a good result with that, it's their option.
According to the 2024 ESCRS Clinical Trend Survey, EDF is one of the most commonly used presbyopia-correcting IOLs among ESCRS delegates. When would you recommend an EDF IOL?
All the time. I think you can, with the current EDF lenses, you can implant them in all patients.
You're right. I agree with that. It's a monofocal profile as far as the
Yes, it's amazing.
is concerned. Yeah,
Yeah, it's
right.
amazing.
And how do you ensure patients are fully informed about the costs, risks, and benefits associated with an EDF lens?
Well, of course, you have to, in the Netherlands, we have co-payment. So the cataract surgery is reimbursed by the insurance company, and they have to pay out of their own pocket for the extra cost for implanting these types of lenses. So you have to communicate that well. You have to inform them that they will need reading glasses. I mean, in the study we did, we found out that 20% never wear spectacles, not for near. So that's a rather high number. And we didn't aim for monovision.
Okay.
So these are eyes, both eyes ametropic. So then even 20% never use spectacles. But I inform them that they have to expect that they need spectacles for reading. Another thing is if you have additional comorbidity like glaucoma or macular degeneration, I think an EDF lens is possible in these eyes.
Exactly.
But sometimes it's difficult to get across what the right expectation for their vision is, because of course the visual field will still be, the visual field defect in glaucoma, for example, will still be there. And sometimes it's difficult to really let them understand that will not go away. So I usually say we can implant an EDF lens, but if your vision is not as you would have expected it, it's not because of the EDF lens, it's because of your glaucoma or your macular degeneration.
You're totally right. We are not miracle makers. We have to make sure that the patient understands that they can reach a capacity that their eyes have already from their comorbidities. And how do you manage patient expectations for EDF IOL during the preoperative consultation?
Well, it's mostly that they still need reading glasses. That's it. And I mean, for far, vision is excellent. For intermediate, vision is excellent. I do say to them, because of course for intermediate, they can work at a computer. In the beginning, I made a mistake that I had assumed that a laptop was also intermediate vision, but it's near. Well, yeah, it depends on the length on the arms. I mean, if you have a 70 or 75-year-old woman in the Netherlands, they're a bit smaller. And they have the laptop much more close. And then it may be difficult. I had one guy who complained about not being able to see his watch anymore with an EDF lens. It was a rather small person. And then your arm is too small. And you have to take that into account in your consultation.
Yes, you're right. Of course. And are there any red flags in your communications with patients that would lead you to not recommend an EDF lens?
Yes, if there's severe comorbidity, and that they will understand that their vision might not be perfect, not due to the implantation of the lens, but due to their comorbidity. And another thing is women, I have to say, because I had a couple of women who were ecstatic about the result of the EDF lens because the vision was so good at far and intermediate. But then I said, why can't I read? Because in my experience, women much more prefer to be able to read without spectacles than men. Many men in the Netherlands, one, they have rather long arms, but they also almost never read. They look at the computer, they look at TV, they do play sports, but women tend to read more. So I'm a bit careful nowadays in helping female patients choose the right lens to see what they really want at the end of the day.
We really have different needs.
Yes.
We do our makeups and all this stuff is different from men.
Yeah.
Anyway, and what's your top advice to maximize patient satisfaction with EDF IOLs?
That's a good question, because I don't think I have a top tip, because EDF lenses are very easy to work with nowadays. One thing I do is that I try to minimize remaining astigmatism as low as possible.
I agree.
I mean, EDF lenses are a bit more tolerant to any remaining astigmatism than like trifocals. They're very tricky, but still, I try to minimize it as much as possible.
That was a very good, very good comment. Astigmatism.
Oh, thanks.
You have to correct it anyway.
Yeah.
Anyway,
totally.
it improves the contrast sensitivity as well. You're right. Thank you for the wonderful interview, and thank you for joining us in this episode of the Independent Medical Education Refractive IOL video interview series. We hope that the shared insights on EDF lenses, along with effective strategies for educating and counseling patients, will help you enhance patient satisfaction and outcomes in your clinic. Until next time,